My name is Peter Cook, Executive Director of the New York State Council of Churches. And tonight it's my pleasure to welcome you to the Council of Churches' fourth public policy seminar, where we invite people to reflect through a theological and anti-racist lens on major pieces of legislation, which will come before the New York State Legislature and also the United States Congress. Tonight's seminar will look at the issue of healthcare. We have recorded our previous seminars on voting rights, the ecumenical movement, including the World Council of Churches, and on climate and environmental justice. And tonight's seminar will be recorded as well. The next two seminars coming up include one on taxation, economic development, and wealth inequality on December 12th, and also another seminar on affordable housing on December 16th. And more details will follow. So tonight, as we look at the issue of healthcare, I wanted to share with you a few brief excerpts of a speech given by Ron Hamill, Senior Director for Ethics at the Catholic Health Association, who offered a biblical and theological framework to reflect on the issue of healthcare disparities. While these words were shared in 2011, not long after the passage of the Affordable Care Act, they're still germane today as we look at healthcare disparities, which are still significant even after the passage of the ACA. Mr. Hamill writes that one of the central themes of the Hebrew and Christian scriptures is the notion of righting relationships or making relationships right. In fact, healthcare disparities are to be considered disordered relationships. And why is that the case? For a number of reasons, healthcare disparities are a violation of human dignity. They violate human dignity because part of respecting human dignity is providing those conditions necessary for human flourishing. And healthcare is one of those conditions. This is a point which was affirmed by many popes, including John the 23rd in Pacem Terris, John Paul II on human work, and Benedict the 16th in an address to the Pontifical Council for Healthcare in November of 2010. They emphasize that respecting human dignity requires that we respect the equal dignity of all, and unequal treatment due to race or ethnicity violates this inequality, this equal dignity of all. Racial and ethnic minority patients receive in the United States a lower quality and intensity of healthcare and diagnostic services across a wide range of healthcare services, procedures, and illnesses. Justice also requires that the goods of society be distributed equitably, not equally, but equitably. Whereas Pope Benedict said in his very same address, an integral part of each person's existence and of the common good is to establish a true distributive justice that guarantees to all, on the basis of objective needs, adequate care. Disparity reflects an unfair distribution of societal goods because of race or ethnicity. Justice requires that citizens have their basic needs met so that they can participate in and contribute to the common good. And as we know, healthcare disparities, at least for some individuals, because of increased illness or serious illness, are not able, are prevented, are hindered from participating in and contributing to the common good. And justice also requires a special concern for those who are vulnerable and in any way marginalized, who may not be able to advocate for themselves and may need others to help them to advocate for their own rights and their needs, and thereby to affect change. So given these brief reflections, tonight I'd like to now turn to Dr. Naomi Zodi, who is the Assistant Professor of Health Policy and Management at the Fielding School of Public Health of the University of Los Angeles, who's going to help us look at healthcare disparities in more depth and highlight for us some of the progress we have made and the challenges which are still before us to address these disparities. Dr. Zodi studies how public policies can reduce inequality in health insurance and in wealth. Her work has been published in academic journals, including Health Affairs, the American Journal of Public Health, and the Journal of Risk and Insurance, and in the popular press like the New York Times, Miss Magazine, and the PBS NewsHour. And so, Dr. Zodi, it's a pleasure to have you with us. Welcome.
Thank you, Peter, and thanks everybody for being here. I really appreciate the goals of this group, and that you're using kind of the power that you have for these ends. You know, I just find it really awe-inspiring. So I just moved over here to LA, to UCLA, from New York, where I was for several years, working at the City University of New York. I was an assistant professor there before I came here. And so I've been studying and thinking about healthcare and inequality in New York for a while. So, okay, let me get started. Now, so we talked a little bit about inequality. So there's two kinds of inequality that we have to deal with and that I'm going to talk about. One of them is represented here in the middle of this graph. And that is the difference in net worth between the median everyday white American household and their Black American counterparts. So these data are from 2016. There's some more recent from 2019, but it got kind of weird around COVID. But really, however you measure it, half of all Black households in the United States of America has less than $20,000 in net worth, and that's inclusive of home equity. Half of all Black American households, they have less than $20,000. And the corresponding figure for white American households is more than 10 times that amount. So the median white household has $160,000, $170,000 at their disposal. And wealth is important for a couple of reasons. One is, it's this financial foundation on which you get to make decisions for the future. You get to plan, you get to live out your life on. So white households and Black households in the United States simply move through the world from a very different financial foundation than one another. And it's also important because, so we've made a lot more progress actually on racial inequality in income and in education than we have in wealth, because wealth is largely handed down from one generation to the next. So, and there just haven't been that many generations since the civil rights era for Black households to accumulate and transmit wealth across generations. So what we end up with is pretty significant racial inequality in a financial foundation. And the other kind of inequality is at the right side of this screen. And it's the fact that almost all of the wealth that exists for any households is held by a handful of white billionaire plutocratic class. So these people happen to be white. Most white people are not them, although most white people do, in fact, have much more than most Black people have. But the problem is that there is a concentration of wealth and power in the hands of a few people. And that is a problem because it gets harder and harder to create policies that are just, that deliver education and wages and houses and healthcare, and that move things around for the people that need them. And so we have to confront both of these problems. We have to confront the whole if we want to have that kind of just society. This is a clip from a show in 1968. This is WNET. It was like a precursor to PBS. So I'm just going to play a quick clip.
In 1940, the infant mortality rate among non-whites was 70% greater than for whites. And 22 years later, in 1962, it was 90% greater.
The slogan for the Black Health Drive is Black Health is Black Wealth. But the fact is we cannot develop Black wealth while we're in ill health. And we have these areas of the city where the infant mortality rate among Blacks is worse than some of the underdeveloped nations of the world. In areas that within 2 or 3 blocks of major white hospitals, you have tuberculosis rates as high as 18 out of every 100. But there has never been a concerted health movement to raise the issue to the point where the American public has to make a valid decision about providing the proper medicine for sick people, as well as the proper education for young people who have the aptitude to be doctors. So one of our concerns within the context of school would be to get students, Black students who have the aptitude to become doctors. Those that have the aptitude to become soldiers, they have ROTC for them. And they pay them and induce them and encourage them to stay in school to become professional killers for 4 years. But there is no program to induce a young man with the medical aptitude to become a professional healer. And it's just so consistent with our nation being 70% inclined toward killing and 12% inclined toward healing to move toward this path of suicide.
So we've been dealing with the interplay between racial wealth inequality and health inequality for a long time. And these inequalities, they reproduce themselves. They don't end themselves on their own, right? So we have on the left, this is like population adjusted COVID cases by zip code around New York City. And it looks a lot like maternal mortality across the city, which harkens back to exactly what Jesse Jackson was talking about in 1968. So these inequalities reproduce themselves over time until there is a concerted effort to address it. So healthcare in the US is particularly inequitable these low income and high income is defined as above and below median income. Below median income, 39% of households say that they did not visit a doctor because of cost within the past year, but had a medical problem. And only 17% of the high income households. But the crazy thing is that in other countries, low income households are even less likely to have that occur to them. So it's highly inequitable, but also just expensive in the US. Not only is it highly inequitable, it is highly inefficient. So, okay, on the left here, we have healthcare spending as a percent of GDP. You might have seen this before if you've ever looked at anything in the US. Healthcare spending, I know in health economics, this is like one of the kind of the central problem of the healthcare economy of the United States, how are we spending so much more than every other country? And yet, when it comes to life expectancy at birth, we are the extreme outlier in exactly the opposite direction. So that's highly inefficient. We are highly inefficient producers of health. But it's not just that we are highly inefficient producers of health, we're highly inefficient producers of medical care, right? So we're spending all this money and it's really not clear what we're getting for it. We're not getting health, but we're also not actually getting health care. So this is the US, we have fewer than average physician visits per capita. We have fewer than average physicians per capita, and then we have more chronic conditions. And it's not just these particular outcomes. We don't use more MRIs. You know, in Japan, they use a lot of MRIs. We have shorter average length of stay in the hospital, conditional on diagnosis upon admission. We have fewer number of hospital beds available to us per capita than the OECD, you know, the other developed nation average. So on almost every measure, we use less healthcare, we are less healthy, and yet we spend a lot more money for it. And we spend more and more every year on health insurance coverage, even as the quality of that coverage is falling, right? So deductibles grow faster than wages every year, year over year for the past more than decade. And so what's happening is that whether it's explicitly like in union negotiations, or it's just an employer trying to decide whether or not to hire somebody and how much to offer them, there are wage concessions that are being made in favor of healthcare. And so effectively that taxes every industry in the United States. Whereas in other countries, they're spending a lot less money on healthcare. It's cheaper to hire another person and produce another widget than it is to do the same thing here, because we have to spend so much more on healthcare. And the thing is, it's just a really complex puzzle. And that in and of itself is what costs so much money. The fact that we have so much fragmentation and so many different, like providers, insurers, rules to negotiate all across this really fragmented system, each of those people costs money, and each of those puzzle pieces costs money. And that's what's so unique about the United States that we don't have in other countries. So this is it, year over year, we have the top line is deductibles, followed by premium contributions, and then finally median incomes. Deductibles grow faster, followed by premiums, and then finally wages. And so we're spending all this money, and again, it's like not clear what it is that we're getting for it. This was, I don't know if there's any Redditors out there. This is like my social media of choice, but somebody says, ask me anything. I was mauled by a bear, fought it off, and drove 4 miles down a mountain with my face hanging off. And somebody asks, what did you find was the hardest to overcome on your path back to recovery? And her answer was Blue Cross, hands down. So, we spend all this money on health insurance, and it's just not clear what it is that we're getting in return. So the last time that we made a huge effort at improving healthcare, the last big healthcare reform was the Affordable Care Act. And the ACA improved access for a lot of people, but we still have challenges remaining. So the ACA had these two kind of arms that it advanced. One was expanding access to public coverage through Medicaid expansion. And the other one was reestablishing the non-group, people who get insurance, not through their employer, but on their own, how they go about doing that. So one thing that I found really interesting about that process was that almost every organization that tried to guess how that was going to play out was wrong in their anticipation, in particularly this way. So these numbers are from the Congressional Budget Office, but it wasn't just CBO, it was RAND, Lewin, CMS, all of these different organizations, these forecasting organizations. And the way in which they were wrong was that they thought that way more people would want the private insurance option than ended up signing up. And they thought that way fewer people would want the public coverage than ended up signing up for that. So you could see on the left here, this was the projected enrollment in the private insurance exchanges. These are their projections. And then down here, this is the actual enrollment in black. So they were off by a good, 10 or more million people. On the right side, it's the anticipated enrollment in Medicaid. So the lighter blue here at the top, that was when they, before the Supreme Court decision that said states got to choose. So once they realized that states got to choose, they revised downward how many people. And so down here, this is their May 2013 projection before it actually went live. And it was way lower than the number of people who ended up enrolling. And so some of my earlier work was trying to understand why this might have happened. Why did more people sign up for the public coverage than expected, and why fewer in the private? So, you can find, and these are two of my studies, but there's a voluminous literature out there showing really substantial financial benefits to households when a state expands Medicaid. So we see reductions in the rate of poverty. We see reductions in home evictions when a state expands Medicaid. I've also found reductions in GoFundMe campaigns for medical care when a state expands Medicaid. And, the thing is, like, Medicaid is free. Once you get it, there's no premiums. There's almost no copays. There's no deductibles. You might pay $1, $2, $3 maximum to fill a prescription. And it turns out that that's really important for households when they're looking for health insurance coverage. Now, the private insurance exchanges, on the other hand, so this was a study that I had that showed that looking at people who kind of the main target audience for these private insurance exchanges, people who, weren't eligible for the public coverage and who didn't have employer-sponsored insurance. For about 1 out of 4 of them, it's cheaper to file for bankruptcy than to reach the deductible of the subsidized benchmark tier of coverage in the ACA private insurance exchanges. So basically, they're just really high deductible health insurance policies. And the problem with high deductible health insurance policies is that you're probably just going to pay for all your health care all year long, unless something catastrophic happens. And then maybe, you'll go past your deductible and they'll start chipping in. But for a lot of these households, you're paying a few $100s worth of premiums out of your pocket every month. And then you go to the doctor and you're still paying the doctor for that healthcare, or for most of it. And so it just can't really offer financial protection for most of these households. And so, I figured that this might have something to do with why people weren't quite so keen on signing up for these policies. And really, when I was just getting my dissertation, like getting my PhD, these were some of the findings that were coming out of my dissertation. And I was like, this was pre us finding out that not that many people were signing up. And I'm looking at these projections and I was kind of like, I wouldn't project quite the same outcomes. It didn't make sense to me. I don't know anybody who would want to do that. And slowly, everybody started revising their projections, and I started to realize that, like, okay, I think that this is my avenue professionally. I'm not so sure that people who devise these policies know people who rely on them. So today, just looking at the way that households spend money on healthcare, it's a pretty regressive distribution. So overall, the higher your income, the lower a percentage of your income you're probably spending on healthcare. So it's kind of flatter just right here, as these are kind of households that are eligible for Medicaid or more likely to be eligible for Medicaid or better subsidies. But then From there on, it starts to fall. Now, the thing about having a healthcare system that is public or publicly financed or tax financed is just that you get to decide what that distribution looks like. So, for example, I estimated a set of tax rates that would be enough to pay for the entire American healthcare system. And, so instead of having it fall with income, if we had income tax financed healthcare, we could choose to have it rise slightly with income. So the point about having it tax financed or just having a public healthcare system is that it can be free at the point of service. So that's equitable. Everybody who needs it gets it. And then it can be financed through a kind of more rational basis for who is capable of contributing. And meanwhile, it has all of these other benefits when you do it that way, like you reduce all that fragmentation. So now you can actually address that factor, why is it that the US spends so much more and gets so much less? There's all this administrative waste. If we had a little bit more of a rational system for financing healthcare, we could get rid of all that waste and start to fall in line with some of the other, all of the other developed nations. So why aren't we doing it yet? There's a major barrier is just this kind of collective resignation to the idea that the world, couldn't be better, that these ideas can't possibly win. But, in Canada, for example, one province implemented a publicly financed healthcare system. And so there's no reason why one state couldn't start in the US. And there's a good chance that that'll be the route that'll ultimately get us where we need to be. But in the meantime, we have these like dual problems. First of all, 1 in every 276 Black Americans died of COVID. We don't really have like systems that are designed to protect us from collective threats that are disproportionately carried by, more vulnerable members of our population. But it could be better. So I think that's a good time to hand it over to Mark Hannay.
Thank you, Naomi. Some of that data I've seen in various ways and others is new to me. So I guess my only comment would be one has to be careful, I think, generalizing too much about the Affordable Care Act. It's a limited law in terms of ambition for sure, because it all kind of varies depending on what state you're in. And so, because a lot of it is structured as a law to be something that is allowed to, and intentionally varies by state. So, some states are better than others. I think I'm happy to report that on the spectrum of things, New York has been one of the lead states on as robust as we can implementation of the Affordable Care Act. California, where ours is also one of those states, to get the most that we possibly can out of it and make the best of it that we can. So we should count ourselves lucky that we're in New York, quite frankly, and not in Mississippi or Louisiana or Texas or any of that. Because those states don't do so well. They have, higher Black and brown populations. The people who are left out in the cold, literally in many cases, are disproportionately Black and brown people. I'm not telling you anything you don't know, I'm sure. But anyway, so from the sublime to the ridiculous, maybe, is a way to think about transition here. I think Naomi has painted a ideal picture of where we absolutely want to go, need to go, must go. So like, here's where we are, here's where we want to go, like how do we get from here to there? I think is the question. And so in terms of politics, it's often done for better or worse in sort of incremental steps. So I'm going to talk a little bit about sort of what's happening at the immediate moment around healthcare, both at the federal level, and then look at the federal level. The state legislature is out of session until January, so there's not much going on here at the immediate moment. And then look a little bit in a crystal ball, admittedly, at what's maybe happening in 2023 at both the national level and the federal level in terms of legislation and policy making, where advocates stand on some of those things. And I'll try to remember as I go along to sort of thread through it. What does any of this mean, either as a whole or pieces, for people who are treated inequitably under our healthcare system, current healthcare system. So now I am not a Zoom whiz here, so bear with me. I'm going to share my screen. Share my screen. Go to what I want. Share it. Okay.
Mark,
Yeah.
would you just introduce yourself? a
Oh, I'm
little bit
sorry.
and
Sure.
say who you are, if you wouldn't mind.
Sure. So let me think. Slideshow from beginning. Okay, there we go. So here's my particulars here. I'm executive director of Metro New York Healthcare for All, which is a citywide coalition here in New York City of community groups and labor unions. We came together about 30 years ago, initially to be supportive of the then Clinton Healthcare Reform Initiative of the early to mid 1990s, which unfortunately did not succeed. And since then, we kind of kept going with our core mission being universal healthcare, but also working on strategic campaigns and in various coalitions to sort of advance strategic issues that we think are important and that underlie the fundamentals of a just universal healthcare program. And so in that capacity, I've also been involved at various local, state, and national groupings of healthcare advocates with various names that have sort of come and gone over the years. But one of those groups is Healthcare for All New York, which is a statewide consumer health advocacy coalition here in New York. It's been around since, I guess, about 15 years now. And I've been one of the co-chairs of the steering committee since its founding, along with Citizen Action of New York and the Community Service Society of New York. And then for the last decade or so, I've been one of the leaders of the Healthcare for America Now campaign here in New York. HCAN, as we affectionately refer to it, was the broad umbrella coalition of 2008, 9, and 10. Labor unions, faith congregations, professional associations, community groups, et cetera, that all came together to push fundamental healthcare reform legislation through Congress that we now know as the Affordable Care Act. Its organizing structure was built in an unusual way where the campaign actually existed primarily out in the states and localities as opposed to within the Beltway, although there was certainly an inside the Beltway component to it. But all of the organizing and energy and resources went out into states. And so we had a coalition that came together here in New York that I helped to lead along with a former colleague from Citizen Action who retired about a year ago. And since then, I've been kind of leading that effort forward by myself. And hopefully I'll be able to bring somebody else in because it's always nice to lead in partnership with somebody else who's got your back in case like you have to take your dog to the animal hospital or something on the day you're supposed to lead a Zoom or whatever life throws your way. So at any rate, HCAN is a group that's worked on healthcare issues at the federal level, particularly here in New York, focusing on the New York congressional delegation, which now in the new Congress will have 26 members, our two senators and so forth, and issues that are at play at the federal government level. So now let's see. All right, here we go. So here's where we are now at the federal government. We're in a current lame duck session where the election is over. The current Congress continues, wraps up business before the new one takes over in January. It's called the lame duck Congress. And sort of this is the larger context in which federal issues will be at play really over the next probably 4 weeks. The prognostications at this point is that they've got a lot to cover and get done, and they're probably going to go right up almost until the Christmas holiday weekend to get everything done that they have to do. And if you know anything about Congress, they only really ever act when they have to, when deadlines are staring them in the face. And so now it's one of those periods. So they have to do a government spending bill, and there's a couple options. Do an omnibus bill that will shove all the individual appropriations bills together, or continue what's a strategy often employed called the continuing resolution, where you keep the government open and operating under the current budget paradigm for a certain period of time, whatever you decide. And then they also want to do some supplemental appropriations. These are things that will not go into a baseline budget from year to year, but are things they want and need to spend money on for a particular given budget year. So that is continuing to do stuff around the pandemic to mitigate it, vaccine programs, testing, et cetera, et cetera. Disaster relief programs. This is particularly for states that have been hit by hurricanes in recent weeks and months. And a piece of that will be temporary expansion of Medicaid eligibility to people in those states who've lost their jobs or homes or whatever as a result of disasters. And then you support for the defense war in Ukraine. There will also be, and this often comes up, end of year budget negotiations, what's called tax extenders, where certain provisions that exist in federal tax law that benefit certain sectors or industries in the economy are up for renewal or expiration or whatever. And there's a bunch of them and this year that refer to the Trump tax cuts that were passed in 2017 that primarily benefited large corporations and the ultra rich. So those are going to be in play, come up for discussion. And so our job, progressive advocates, we continue to call for making large corporations and ultra rich people pay what they owe in taxes, pay their fair share, to promote a new billionaires income tax idea that President Biden put in his budget proposals earlier this year, and link anything that's happening around tax extenders in the next 4 weeks for the budget year going forward. Link it to expansions of the child tax credit and earned income tax credits to all low-income families, whether they file taxes or not. That's what's called full refundability. Anybody can claim the refund and should claim the refund. It's one of the most successful anti-poverty programs that's been developed. There was a temporary bump in these programs during 2021 when the pandemic was still raging, and it substantially lowered the child poverty rate by as much as 50%. Unfortunately, it was only in place for 1 year. So the idea here is let's bring that back and make it, put it in place for 3 years. And hopefully by then it'll have enough political real world impact that will be hard to sort of repeal it at that point. But the most important thing around the next section of the lame duck is there's going to be a fight over whether to include raising the debt ceiling limit for the next 2 years. You may remember 11 years ago in 2011, there was a big fight over the debt ceiling where the US almost defaulted on its debt, literally up to almost midnight of the day. And so we don't want to go through that again. it caused a lot of not only stress, but it really upset the financial markets and so forth. So it was not a cool thing when all was said and done. And at that time, the Republican, then new majority in the House, was trying to force cuts to Social Security, Medicare, Medicaid, and a variety of social programs. They're going to do the same playbook again, and if they have a chance in 2023, when the debt ceiling will have to be raised at some point. And so the idea here is let's raise it now while the Democrats are still in control, take it away as a cudgel for the Republicans for the next 2 years, and we won't have to have that fight. Is sort of the thinking there. Then our advocates, federal healthcare issues that we're pushing for Congress to set guidelines and guardrails for how states and action states can do and take when the federal public health emergency finally starts to go away. It's still technically in place. Anticipation is that will start going away sometime during the early to mid part of next year. And so a lot of people have gotten onto public insurance programs during the pandemic, and they've been able to stay on them under the terms of this public health emergency. But once that goes away, then everything will sort of go back to the way they used to be. So in that process, advocates are saying, let's make Medicaid eligibility 12 months long. Once you qualify for it, you're in it for a year rather than having to renew every 6 months. A lot of people fall out of the program at that point who should be staying in it. To make permanent some actions that were taken under the American Rescue Plan Act of last year that was primarily around pandemic relief programs. There was an option for states under that to offer 12 months Medicaid coverage to postpartum low-income women. And it had a really positive impact. I'm sure Naomi can speak to that. She's probably familiar with that literature better than I am. But at any rate, to keep that option permanent for states to take up. New York has taken it up. And for states to be required to reinvest any Medicaid savings they might accrue as the public health emergency winds down, that those savings be plowed back into Medicaid and other healthcare programs that directly benefit people, as opposed to others, healthcare stakeholders, or just using it to balance the books. There's a piece of legislation called the Pregnant Workers Fairness Act that's got some good political legs. Looks like it's going to be able to go forward to provide some new protections under federal law for pregnant women workers. Making the state child health insurance program permanent. It's comes up for renewal every 3, 4, 5 years. It's always had strong bipartisan support. Congress is sort of saying, like, why do we have to do this year, every so few years? Let's just make it permanent and be done with it. So that's on the table. There's some cuts that are scheduled to go into effect, Medicare reimbursement rate cuts to hospitals that they want to stave off. This is another one of the typical end of the year things that happen. It's been happening for about a decade now. There was a law passed back then that would schedule these cuts year by year by year, and Congress has pretty much avoided them year by year by year. So it's sort of a meaningless thing. It's sort of a dance they go through, but they have to go through it. And then we want to continue to make noise about creating an ACA Medicaid expansion workaround for those states that there are 11 states now that have yet to expand Medicaid under the provisions of the Affordable Care Act. They're almost all in the South. It's about 4 million people affected, and 60% of those folks are low-income people of color. Okay. So other issues, things to think about for looking ahead to the next Congress. And again, I'm crystal balling it here very much. The new committee chairs in the Senate, Senator Bernie Sanders will be taking over the committee that handles health issues as chair. Senator Ron Wyden will remain in the Finance Committee. That's important for health because Finance Committee oversees Medicare and Medicaid, the two big federal healthcare programs. There will be new Republican House chairs and Democratic rankers. Those are the highest minority party folks on each committee. They're called rankers in congressional speak. Those will all be announced by the House leadership in January. There's no likely attempt this time, for the first time in 12 years, to repeal and replace the Affordable Care Act. The ACA is in place, for better or worse. They might do, Republicans might try to propose some nibbling around the edges under the frame of flexibility for markets or states, but more or less the bill and the framework it lays out is going to be in place. There will be some possible bipartisan bills, all likely modest in scope, driven by centrist politicians in each party, around the opioid epidemic, expanding mental health, regulation of pharmacy benefit managers. These are these special sort of middlemen entities that exist between drug companies and insurance companies and employers that self-insure. They're very new within the healthcare sector last decade or two. They're very much a black box, very unregulated. This is definitely needed. And then there's going to be efforts to expand insulin out-of-pocket cost caps to the private insurance sector. They were expanded to Medicare under the recently enacted Inflation Reduction Act law of last summer. And those caps will go into effect starting this January for Medicare, people on Medicare. So there will be attempts to move that same paradigm over into the private insurance world. Now, that does nothing to lower the cost of insurance that drug makers charge. All it does is limit what you have to pay out of pocket when you go to the counter and pick up your prescriptions. Whoops, what have I done here? There we are. The standards under Medicare are that each prescription is no more than $35 per prescription per month. So it'd be a similar kind of thing. Then they're going to be what call these message bills. And those are things that may pass one house or the other, have strong support in each party. Nobody expects them to be enacted by both houses and or get to the president and get signed. But they're a way that each side sends out messages to the public about what they would really like to do if they had their druthers. So Republicans, since they'll be new in the House majority, they're going to look to scale back Medicare and Medicaid spending. They're going to look to expand the privatized Medicare system known as Medicare Advantage. They're going to look to instill work requirements for Medicaid, possibly food stamps and other public programs. They're going to look to repeal the prescription drug pricing provisions that were included in the Inflation Reduction Act, which, by the way, are a couple years away from implementation. So I don't know what they're so flipped out about, but anyway, they've always done big pharma's bidding, and this is yet another example of that. And they'll be talking about abortion bans and limits. On the Democratic side, there will be efforts to talk about expanding the traditional Medicare program to include dental, vision, and hearing, and to pay for it by taxing large corporations and billionaires. That's sort of the basic healthcare paradigm, I think, but if the Democrats are smart, that's what they'll put forward. All of that is strongly supported by the public across the political spectrum. So it's a win-win-win issue for the Democrats to put that forward. They're going to talk about instituting annual out-of-pocket cost caps for the parts of Medicare where they don't exist yet. They're just putting them in place for Medicare Part D for drugs. That will go into effect in 2025. And in the meantime, they want to institute similar caps for Medicare Part A, which is hospital care, Medicare Part D, doctors and outpatient. They're going to talk about drug pricing, controlled drug prices, and the patent abuse that the drug industry has mastered par excellence over the years. these provisions of going after big pharma are extremely popular with the public, again, across the political spectrum, like 80–90%. You don't see numbers like that when you do public opinion research. Everybody's now hip to how big pharma has been ripping us off for years, and they want it to stop. And then, of course, there will be proposals from the Progressive Caucus to advance universal healthcare, Medicare for all ideas, and to hold that out there as kind of the beacon where we need and must go, as Naomi was talking about earlier. Then here, New York, we're bringing it home. I got a couple slides and then I'll be done here. Larger context for taking on healthcare issues this year. These are things that won't come before the legislature next year. They're things that are already in process to varying degrees. So the first thing I talked about a little bit ago on the federal side will also be something that will come to the fore on the state side. And that is the wind down of the federal public health emergency. That again is likely to start sometime in the first half of next year. People who are on Medicaid will have to recertify again. Because of all the new people that have come into the Medicaid program during the pandemic and federal health emergency, we now have 8 million people in New York on our Medicaid and other public programs like CHIP and the Essential Plan. And that's well over 40–45% of our state's population. And to have 8 million people recertified over the period of about 14 months is going to be quite an undertaking. And so our goal is to make sure that everyone is preserved, that nobody falls through cracks as they transition from one option to the next option, that it's smooth and seamless and coverage stays in place, that care is not disrupted. All that's going to have to happen. The good news is the Commissioner of Health and her staff are well aware of this challenge. They're doing planning of it. They want to do the best job they possibly can. So we're in good hands. But that noted, it is something we're going to have to be watching and paying attention to. There's a new federal Medicaid waiver that's about to be finished negotiating. That I have some ideas for how to address and advance health equity in New York, and will be functionally operate on regional basis. So stay tuned for more details on that. We'll be implementing the new Health Equity Assessment Act that requires when hospitals merge, downsize, close, et cetera, that they must conduct an independent health assessment of what will be the impact on those health equity in communities when that happens. And that'll start up July of next year. And then there are things that are going to be implemented that were done in earlier this year as part of the state budget process, expanding Medicaid to more low-income seniors and people with disabilities to make it comparable to standards set for everybody else for Medicaid under the Affordable Care Act, including raising the asset test limit, expanding eligibility to Medicare, what's called Medicare savings programs for lower income people on Medicare who don't currently qualify for Medicaid. These programs help people with their out-of-pocket costs to use the Medicare program, which can be quite substantial, particularly if you get really sick. And then expanding Medicaid to all low-income immigrant seniors over the age of 65. Sorry, there's an ambulance going down my block here. These are all low-income immigrants for the first time, regardless of documentation status. So this is really a significant shift in New York State policy for healthcare for immigrants, and it's something to be celebrated and congratulate ourselves to. It's a modest first step, but we've made it, and a precedent has now been set. Looking to our priorities for the coming year, they fall into 3 buckets. one around insurance, one around access to care, another around consumer rights and protections. In the interest of time, I'll just quickly show these slides. I'll make them available to Peter. You can send them out to people so that they can read them. But essentially, it continues to
Art?
build on expanding coverage for immigrants, for children, for seniors, people with disabilities, repealing some limits that came in the closing days of the Cuomo era, providing people with assistance to navigate and get enrolled in insurance coverage, to find out about those programs, to allow our Medicaid to grow as a program, our state's Medicaid program to grow as needed rather than be artificially constrained by the annual growth cap, to strengthen oversight of managed care programs for people on Medicaid, better support for home care workers, for safety net institutions and hospitals, particularly in rural areas, to require all hospitals to have independent community advisory boards that have meaningful roles, working with hospital administration in their communities, and to explore ways that the state can help reduce and moderate healthcare costs and cost growth, particularly hospital services. And I know Alex is going to talk more about that in a minute, so I won't steal any more of his thunder. But I think advocates, generally speaking, are very much on board with this is something that must be done in New York. Other progressive states are doing it to success, and we're behind the curve, and we need to, step up to the plate. If I can mix my metaphors there. And then lastly, consumer rights and protections, protecting people against unnecessary medical debt, particularly if they're hospital patients. There are things that New York can do. We have a system in place supposedly to protect them. It's not working so well. And so the idea here is let's modernize it, streamline it, expand it to cover more people, protect them from debts that they simply will never be able to pay. The leading cause of personal bankruptcies has long been medical bills. We know that, particularly for when you look at the data, it disproportionately affects low-income communities, Black and brown communities, and so forth. And so there are things we can do.
Excuse me, friends who aren't speaking, could they please mute?
Yes, sounds like somebody's eating dinner. So if you're having dinner, bon appetit, but please mute yourself. Thank you.
Yeah.
To require hospitals to disclose when they don't provide services, certain services to their community for non-medical policy reasons, to provide cost of living adjustments to consumer assistance programs that New York set up under the Affordable Care Act and does. We have great programs, but they need a cost of living adjustment and they haven't gotten one in a decade. So it's time. And then create a new ombuds program for people with intellectual and developmental disabilities. So that's kind of the agenda in a nutshell. And
Mark?
Head
Mark?
back to Peter. Yes.
Yeah, could, you still got a little more time if you could, was there anything in there you wanted to expand or elucidate a little more? Because for the record here,
Whoops.
so.
Oops, what am I? Are you seeing something on the screen now or not?
No.
Okay. There we are. Okay.
Yeah.
No, I think I'm pretty okay. I breezed through some of that a little quickly, so maybe in the Q&A, if
Okay.
I guess I would just say that this is one thing I often stress to people, and particularly when I have interns, is that it's all well and good to have a good healthcare policy in mind that you want to get enacted, but the flip side of that coin is what's politically possible at any given moment. And when do windows of opportunity open that you could take advantage of to push significant ideas forward? They don't always happen. They're sort of cyclical in nature. And so when that window is not open, what are you doing to get yourself ready for when that window does open? Because it will. And you want to take full advantage of it if possible. So I think that's one thing to think about. So it's always kind of this ebb and flow of ambitious and more modest and getting ready and pushing forward. And then, of course, enacting a bill is only half the job. Then you have to implement it and make sure that the other side, which was in opposition legislatively, doesn't subvert you on the rules and regulations side of things. So you got to pay attention to all of that right through to the very end. The Affordable Care Act process has really been a decade in the making, and admittedly it was, and it was not overly ambitious like many of us would have liked it to have been, but it was what it was.
Okay.
A lot of people have, benefited from it. We have a lot more work to do to get to universal health care. And this is true at both the national and state level. So I think that's kind of an overall way to sort of think about it.
Well, we're going to come back at you with some questions, but I think to really see where the top hits are for the 2023 legislature. But I'm going to now introduce to you Alex Wiesendanger, who is with 32BJ and SEIU, and has been really active in the affordable hospital pricing campaign, and succeeding in getting both the Assembly and the Senate to pass the HEAL Act, which is still awaiting Governor Hochul's signature. So, Alex, if you could share a little bit more about you and share with us where we are around hospital pricing.
Absolutely. Thanks so much, Peter. And for folks who don't know me, full disclosure, I also serve on the board of the Council of Churches. So wearing both hats tonight and thrilled to be here. As Peter said, I have the honor to coordinate the Coalition for Affordable Hospitals, which is a coalition of mostly labor unions, but also community faith-based partners, healthcare advocates. And while Naomi and Mark have really given you all sort of the global view, I'm going to be very focused for a second. Now, this is not to discount anything that has been said. Like I think Mark did a fantastic job of helping us all remember how evil pharmaceutical companies are. And that's true. And we've talked a lot about how evil and profit hungry insurance companies are. And that's also true. So let's start right there. But the third piece of this triangle, and the thing that is actually driving healthcare costs the most, are hospitals, which we all don't think of as greedy, profit-driven institutions. And yet here we are. I think at a core, we sort of found ourselves saying this a lot over the last year, that you cannot have accessibility without affordability, right? Meaning that saying I have insurance, fine, but Naomi's research actually pointed to if you can't afford the deductible, or you can't afford the copays, or if you can't afford the insurance plan because it's just so expensive, people will choose, even though it seems odd, to not be insured. And to Mark's point, Mark used my favorite terrifying stat that the #1 cause of bankruptcy in the United States is healthcare costs, right? Healthcare bills. So I want to start. Peter, can I be allowed to share my screen, please?
Oh, sure, certainly.
So I want to start with my favorite graph as soon as Peter will let me. There we go. So this has been called the graph of the decade. And what it shows is truly terrifying. Your timing is so good. So in a few years, my son is going to go to college. And we're all terrified about how fast the price of college tuition has gone up. But you can see hospital prices even outpaces that. Good night, sweetie. Love you. Great timing. He was not intended as a prop there. If Mark had talked a little longer, he would have just come to me before I started talking. Hospital services have been going up at a rate higher than literally anything else in our economy, which is astonishing when you think about having to do things like pay for college or all the other costs that we see going up. So I'm just going to skip through a couple things here, but there's several pieces that I think are really, really important for us to understand. The first is when I talk about hospitals, I actually want to make clear I'm breaking this down into three big groupings. First, there is our public hospital system. In New York City, this is the Health and Hospitals Corporation. They charge incredibly low prices and are incredibly underfunded and frankly should charge more. The second set of hospitals is our private independent safety net hospitals. These are the hospitals that bore the brunt of COVID. We're talking about Wyckoff and Barnabas. These hospitals are really not even a part of the commercial market. Less than 10% of their patient mix is commercial payers. They are dealing almost exclusively with people with public insurance or no insurance whatsoever. So frankly, they're not affecting the cost of commercial care much because almost no commercial patients are going there. And then we have the third group, which is the large private systems. Here in New York City, I call them the five families because there are five of them and they act just like a cartel. These are the New York Presbyterians, the Northwells, the NYUs, the Mount Sinai's, and the Montefiores. Mark's counting, that's the five. And these hospital systems are charging prices that are frankly unsustainable and unjustifiable. The other thing I want to be real clear here is that this is not a difference about quality. Lots of us can talk about how broken the healthcare market is to the point where it doesn't even function like a market. But when you go and buy a car, if one car, costs 3 times as much as another, there's some assumption here that there's something better about that car. Don't ask me for an example. I don't know anything about cars. But in healthcare, we really don't find that. So if you look at this, what should strike you is that these 3 bars don't look that different. And what they are is the price grouping of hospitals, sort of low, medium, and high, and then their quality ratings. And there's maybe some slight difference, but what you'll see is there's a lot of high quality hospitals that charge low prices, and there's a lot of high price hospitals that get medium to low quality scores. So this is not a question of quality, because most of us would say like, yeah, I'll pay extra to make sure I'm getting the best care. What price is related to is market power, and then the ability to put out really nice commercials to tell you that, going to New York Presbyterian for your colonoscopy is so much more important than going to HHC. But who's hurt by these costs? The simple answer is everyone. The cost of healthcare depresses wages for workers. It depresses our health funds themselves, and it really cripples our public budgets. And that's actually the last piece that I want to focus on a little bit here. Now, BJ, I'll just say, this slide is way too wordy, but we got into this. It's weird, right? Because we're not the healthcare SEIU. We're the janitors union. Like, we're security guards and janitors and school cleaners and concierges. So why are we in this fight? It's really just because we're very big and we have a health fund, and we're big enough that we've been able to demand our own claims data. So everyone knows healthcare is expensive, but we, since we literally pay every cent of every bill, can see why. And so we've been able to see how expensive these prices are and how unrelated to quality they are. And for us, this is where it was. 20 years ago, 17% of our members' overall compensation went to the health fund. Now it's 37. Over the last 20 years, our members' wages have gone up about 50%, but the cost of our health fund has gone up over 200%. And this means that working people, again, the janitors that clean your kids' school, the security guards at our buildings, not well-off people, have been shorted just over the last decade $5,000 in wages today. Foundational and transformational. And the costs make no sense. So these are some operations that are pretty standard. Like, I never thought when I started this work that I'd spend so much time talking about colonoscopies, but it's a great example because there's lots of them and there's really no quality difference. Like, a colonoscopy is a colonoscopy. It's a standard procedure. It's incredibly uncomfortable no matter where you go. Even at NYU, it doesn't feel good. And yet we see 2 and 3 and 4 times difference pricing charged to our fund for these very basic procedures. And so let's talk about how this plays out. Because we were talking about things like expanding funding for the city hospital system, which is desperately needed, or at the state level, you know, expanding coverage to people who are undocumented. Those things cost money, right? In politics, that's the #1 reason things don't get done. So this is New York City's budget. About 10% of the New York City budget is spent on employee health care. And generally, 40%, roughly 39% of all healthcare costs are hospitals, just the hospital services. And more than half of that is hospitals charging above what it's been calculated they need. So above not just the Medicare rate. So Medicare sets its rates, and this is by law, at the rate that a reasonably efficient hospital system could function on that price. And then there's several organizations that calculate what they call the Medicare break even. So that's if you look at a hospital system and you take into account all their Medicaid patients who pay much less, all their uncompensated care, how much above Medicare should that hospital system charge a commercial payer to make up the difference? The answers, depending on the hospital system, are usually between 110 and 140% of Medicare. So more than half of these costs are what hospitals charge above what they need, above that Medicare break even. Another way to say this is 1 out of every $5 spent in the US healthcare system is simply hospital profiteering. And in New York City alone, that means the city is overpaying by $2 billion a year. That was the amount of the budget deficit that the mayor was trying to figure out how to deal with in the last budget. Just already wealthy hospital systems getting wealthier. And so when we think about this, for each level, individual workers, if they have healthcare, are having their wages depressed. You're paying these prices either by lower wages or by higher costs of your healthcare system, or if you're really lucky, both. You're getting screwed out of wages and paying more in terms of your healthcare. Our public systems are being pulled and stretched thin, and our public budgets at a time when we're going back toward a time of austerity are getting wrecked over the coals, while these incredibly wealthy systems that are supposed to be nonprofits rake in millions and millions and billions of dollars above what they need. So how do we tackle this problem? The first thing we started, as Peter said, was a bill that was just trying to take on some of the most egregious tools that hospitals use, which is the term often used is anti-competitive, but I don't think that really gets at it enough in terms of their contract clauses. So these were clauses that big hospital systems, and again, only the big ones have the power to insist on them, put in their contracts with your insurance company or your third-party administrator that you don't even know, that drive up prices. And I'll highlight a couple because Naomi talked about maternal health. So I'm going to tell a story. 32BJ's members are overwhelmingly Black and brown folks. And as Naomi alluded to, maternal health outcomes for Black and brown women are a travesty. We saw these same outcomes and so said we want to design a high quality maternity care program for our members. And we did. We put out a series of questionnaires. We demanded data from all different hospital systems. And we selected a few that we could be assured had really high quality outcomes. And we began steering members toward this program, which cost nothing out of pocket for members because that was so crucial. New York Presbyterian chose not to participate in the program. They wouldn't provide any quality data or show us that they had the outcomes we needed. Now, fine, they don't have to participate. And then when we went back to renew our contract, they said, you cannot have this program unless New York Presbyterian is in it. We have a clause in our contract that says that, even though we're going to charge more than every other hospital, and we won't show you the data that says that we're in it, that we have the same quality outcomes. They basically said you have to kill a program to guarantee free, high quality maternity care for Black and brown women because it doesn't generate profits for our institution. And they were allowed to do that through what's called an anti-steering contract term. These were some of the terms that HEAL was hoping to outlaw. Now, in the end, unfortunately, the pushback from the hospital industry was so strong that we lost the anti-tiering provisions in the bill, but we did pass two really crucial ones. The first step of fixing a problem is admitting you have a problem, is gag clauses. As I said, most of your health plans, you are not allowed to know what the prices you're going to be charged are. This is because hospitals insist on gag clauses in the contracts. Those will be illegal now, thanks to HEAL, which is much more data than you get in the federal price transparency laws, where there's this incomprehensible to any human being spreadsheet on a hospital website if they're complying with the law. The second is what's called most favored nation clauses, which is literally a way that a powerful insurer and powerful hospital system go into a back room and just set an artificially high price floor for the whole market. So those will now be illegal when the governor signs the bill, knock on wood. The next step at the city level, we're calling for an Office of Healthcare Accountability. These exist at a number of state levels that can do things like pull together all data, set price targets, chart how hospitals are living up to their nonprofit status because they are receiving billions of dollars of tax breaks. Again, you're in my money. Are they living up to it? We just found a report that found out 9 systems have a cumulative $700 million of what's called a fair share deficit. They take in $700 million more in tax breaks than they put back in community benefits. That's taking, not even counting their prices. And then the third thing is demanding that the state NYSHIP program, the state system, just for state employees, audits how much we're being charged and how much taxpayers are losing due to these egregious prices. So hospitals are a part of this problem. They are not the whole problem, but they are the largest drivers of cost. And they have been hidden. And so our campaign's goal is to bring that into the light and to demand accountability everywhere. I will stop talking now and hand it back to Peter for questions generally, I think, right, Peter?
Yeah, great. So this seminar goes to 9. So we have 35 minutes for conversation and questions. And I'm going to open with the first one, and then I'm going to ask people to jump in, and if the panelists want to dialogue with each other too, that would also be pretty interesting. So, Naomi, the thing that really stood out to me in your presentation was the need to really move to a publicly financed healthcare system. That the ACA, while it was an incredibly significant and important advance, still enables a system where costs are piled up because of administering all these different rules. And it also forces people who can't afford it into high deductible policies. So it seems to me that going to a public single payer kind of system is the right way to go. Can you talk more about why that is so hard to get that in place? And maybe even talk about the New York Health Act. And I also know there was one in California as well, that where they got close, but it fell apart as well.
Yeah, sure. I think, it's hard because it's a big change, and healthcare is, coming up on 20% of the economy. So, and it all pretty much runs through these private insurance organizations. And that's employer-sponsored coverage, but that's also Medicaid is, the majority of Medicaid beneficiaries have their care through a private insurer. Medicare, it's approaching half, and that's increased by a lot in just the last few years. So private insurers command almost all of that 20% of our economy that is healthcare. The dollars flow through them. And so something where you're trying to move them out of the equation is, you're coming up on a very concentrated minority of people who are going to be really harmed. That is the private insurance industry and shareholders. And so politically, New York is further along than California, at least on paper. So we had majorities in both houses of the state legislature co-sponsoring the bill that would outlaw the sale of private health insurance in the state of New York. It would have no deductibles, no co-pays, no narrow networks. All care would be covered by this New York, Health Authority. They would reimburse providers at just above Medicare rates. And so, that would be a pretty substantial change on what we have. And yeah, so you would think, right, if they're co-sponsoring it, then they're going to vote yes. But what happened was this past legislative session, the Senate Majority Leader never brought it to a vote. So we just never really found out who co-sponsored it, out of knowing that it's a good idea, but, maybe not actually being willing to try to advance it. So, but I think that so part of what's also difficult about it is that right now we have these different hospital organizations that have different payer mixes. So some of these are, say, public hospitals that most of their patients are paying with public coverage, like with Medicaid. And so, that problem is in itself, like the fact that Medicaid pays less than private insurance to doctors, which it does nationwide. And New York is, I think, on par or worse than the nationwide average. But on average, Medicaid pays less than Medicare, like around 70 cents on the Medicare dollar. And so what we do effectively is say that people who have public coverage, that public coverage pays doctors less. So a lot of doctors are just not going to be willing to take public coverage. So we have in effect created a segregated system of who can access which providers. So it turns out, as one of the benefits of a single payer system, it's, you know, the waste is the equitable source of financing, but then it's also everybody gets paid in an equitable way. And so it's not just the private insurers that you're cutting out as middlemen who will be against it, but also potentially those hospitals who only see private insurance patients. Equity would mean they get away with less. So on average, for most physicians, they like, you know, so there was the Rand Corporation did a study of what would happen if we implemented this. And it's the most thorough evaluation we have for what it would look like in New York State. And they found that physicians, like your average just doctor, is net better off, because even if they have more private insurance patients, you know, every doctor's office has to hire a couple of people, usually women, who like call all these different insurance companies and figure out which forms to fill out to make sure that they're getting reimbursed on time. So the doctor's office on net might get a little bit less money. They're making, you know, more than Medicaid, more than Medicare, but less than private insurance. But they also have a lot less administrative expenses. So on average, your average doctor is better off. But there are some hospitals who perform like high cost procedures and who only have private insurance patients who could stand to lose with the advent of equity. So, you know, so mainly you're up against private insurance companies, but there are some high revenue hospital centers that would stand to lose as well.
Mark or Alex, do you have any additional thoughts on the New York Health Act and how that intersects with what you do?
Yeah, I'll just add on two things to what Naomi said, which was all 100% right. I mean, we did not even talk about the really ugly phenomena that some of my colleagues who represent doctors told me is what Naomi referred to. It's called patient dumping, which is the big systems literally have people whose job it is to steer public, patients who have public insurance or who are uncompensated, don't have any insurance, into the safety net hospitals and the private system. So just on that, it's those five families, again, in addition to insurance companies, who are opposed. And unfortunately, those five families are also the money behind, and therefore the people who pull the strings of the Greater New York Hospital Association, which in New York is the largest lobbying entity in terms of dollars into the state legislature. It is the largest in the state, it is the most powerful. And so you have these same problems, that you've got huge insurance companies that profit from our system. You've got huge hospital systems that really profit, even though they're technically nonprofits, from our system. And that's the big holdup, in addition to just it's a huge thing, and change is scary. Mark will have more to say, but I wanted to jump in on patient dumping because it's so nasty.
Yeah, and oftentimes the way that geographically New York's public hospitals are often down the block or across the street from the rich, well-off hospital that literally sends the people, if you don't have the right insurance coverage, they say go over there. And you don't have to scratch the surface to see that that's racially discriminatory. I mean, it's so blatantly obvious. But anyway, the New York Health Act. The challenge, as both Naomi and Alex said, it's a political challenge more or as much as anything else. That and the shift away from sort of the devil to one you don't know, that actually might be an angel, but you don't know that, and so the whole reassurance over the transition. How do you get from here to there in a way that at the very least protects the patients, keeps care going and moving, protects the providers that are providing the services, et cetera, as they sort out the restructuring and the money flows and all that sort of stuff. So, and there's a lot of different stakeholder constituencies that have opinions on that. Some of them more parochial than others, but nonetheless, sort of politically sorting through all that is really a challenge.
Okay. Shauna Williamson, I'm gonna let you ask the next question. You have it up in the chat.
Oh, well, good evening, everyone. There were two questions that I asked pertaining to things that were being said by two of the representatives, Alex and Naomi. However, I don't think anyone explained the theological perspective behind this. There are a vast majority of people that are religious. We do have a lot of health care systems that are in conjunction with religious services like Catholic health systems. They're named after saints and everything like that. I'm more about like self-perseverance, self-sufficiency, taking it from a theological perspective. So like with anti-racism, we have to take it from a broad perspective. And also with healthcare reform, because with the Affordable Care Act or healthcare reform, it aimed to reform private and public health insurance systems. I wish I had a whole, slide and everything for you guys prepared, but I don't, I didn't know what this would actually entail. So, we have like a couple of issues in our community. We're talking about like environmental. So if we go on the environmental aspect of it, we're all affected. We go outside, we have bird droppings. Birds could cause over 60 diseases. Naomi mentioned something with bears. We have to think about our livestock as well. The vegetables and fruits that we eat, that bear may have been sick. And in response, I'm not taking up for the bear, but it's a defense mechanism. Also, there was a woman, she went to visit her friend one time and she had to have facial reconstruction. So this goes with like medical law and ethics. Is that like an ethical procedure? Is it ethical to have an animal that large in your home? So, we talk about, certain things, but we also have to take a good look or think of it, just take a different look at it, a different perspective. So I understand everything that everyone is saying. It's good, to talk about funding and sources, who would, pay for this, public versus private. But I think, what it all boils down to is just equality on a broad spectrum, because everybody is affected. If there's a water crisis going on, it's not only going to affect somewhere in Texas, it's going to affect, places in like Alabama that just, suffered from a water crisis. Places like Flint, Michigan, it hops from place to place. So if we address this on a broad spectrum and not necessarily put it on like race or necessarily religion, because there's like an interfaith community and it goes with culture and everything like that. I think it would be, much better, to handle it that way, to think of it as a broad spectrum, like it's affecting everyone, even the healthcare providers.
Okay. So there's a lot there. Our panelists, you like to take a bite on this?
Well, I would say that hospitals certainly do affect us all, because they kind of have to be there. So imagine there is, a situation like COVID. They affect large numbers of people, and we just have to have pre-existing healthcare capacity available in case these things happen, if we want to function healthy as a society.
Right. I'm sorry, Naomi, but if we speak about COVID, if you look at the history of infectious disease, that we just got over the flu pandemic. So these are different things that come into our community. So COVID actually started off as MERS. And if you look at the timeline of what happened during COVID, there was actually an explosion in Texas. Okay, and that chemical can cause symptoms of COVID-related illnesses. So I'm not sure, just like the dust from the Sahara Desert cast over to the United States, if that may have been the cause of COVID-19. And because we don't have proper air quality measuring systems, or maybe that was not seen as a importance at that time to test the air quality, then this is why we had so many fatalities.
Well, whatever the source of any particular disease, if there's a lot of people that get sick at the same time, they're going to need somewhere to go. You know, there could be like a 12-car pileup on a freeway. They're going to need trauma care. And so these
right,
are
but every pileup is different, because there was just an accident in New York City, and it doesn't look like things I see in the Midwest. So, you know, everybody's situation is different, you know, depending upon the investigation and depending upon the factors that surround the situation. So, you know.
All right.
But at the end of the day, like one thing that all of our human bodies may have in common is their frailty, their capacity to experience some kind of illness. The sources, the particulars might vary, but our bodies have these illnesses, and there are really expensive facilities out there that we don't own within our own homes. It doesn't make sense for us to own like our own MRIs or our own, you know, I mean, so there has to be some way for us to share access to the physical technologies and the people, the expertise that where we can go to seek help for those needs. So what we're trying to collectively figure out is like, what is the fairest way to maintain access to that if we have a goal of having, you know, kind of a well-functioning, healthy life for people and kids and adults.
Okay.
Right. So, I mean, a lot of it has to do with environmental. Like there was just this school, you know, that had a couple of graduates, maybe back in the 1990s, 80s, you know, going back that far in New Jersey, and they all suffered from cancer. So again, is it the school or is it the environment? Because again, if birds can cause over 60 diseases, it's either us or the birds.
Right.
Yeah.
You know,
If I
so,
could
you know.
just sort of chime in, I think what you're pointing to, Shauna, is the point of a healthcare system is, along with a variety of other things that you mentioned, enable us to live healthy, right?
Right.
And so the healthcare system is sort of only one end of a spectrum of what we call health. And so I think what we're talking about today is sort of that one end of the spectrum, and its shortcomings and ways to make it better, et cetera, that will then support health. In and of itself, the healthcare system is not going to necessarily guarantee anybody health. There's a variety of things that contribute to health and well-being.
Right, like self-preservation, self-sufficiency, making sure you perform your activities of daily living. You know, it goes a long
You
way.
could rattle off all that, but the point is
Okay.
that at some point, a healthcare system is there to catch you when something bad goes wrong, and or goes wrong for a whole bunch of people all at once. I think that's the point.
Okay, so I'm going to move on to the next
Sure.
question. Thank you. Catherine Darcy.
Thank you for that presentation. It was quite helpful to me, and I learned a lot. I have been in touch a little bit with the Poor People's Campaign in New York, and one of their issues is to end medical debt. Does that play into you know, any of the bills that you're promoting, Mark?
Yeah, actually, and it's somewhat the flip side of the problem that Alex laid out for us. You know, people end up in medical debt, and the biggest source of medical debt is hospital bills that they just can't pay. Whether they have good insurance, crappy insurance, no insurance, like what happens under that? So New York put a system in place about in the mid 2000s or 2000s. It was a 15-year campaign to get it passed, but it was a law that requires all hospitals to have what's called a financial assistance program for their patients. And at a minimum, people up to roughly 300% of the federal poverty level can qualify for these programs. Some hospitals go higher than that, depending on what they see as their charitable mission. But anyway, it's eligible for that. And sliding scale help. So the lower your income and assets, the more help you get, kind of thing. But they're all required to do it. But there were no uniform standards set. The state really hasn't monitored and enforced it. In the meantime, we still continue to shove billions of dollars into hospitals for uncompensated care that's supposed to mitigate or prevent this medical debt, but patients are still walking out the door with bills they can't pay and getting sent to collections and having court cases and et cetera, et cetera. So there's sort of a whole campaign that's built. It's been around about 3 or 4 years now, the End Medical Debt campaign, which is about sort of helping patients out in these crisis moments and helping mitigate that debt to some degree or eliminating it. And we've been able to pass, you know, this thing, that thing, the other thing, the other thing. So the campaign for this coming year, 2023, is going to be about reforming that hospital financial assistance system that we have here in New York to make it more streamlined, make it more hospitals all operate the same way, that patients are told about it, that it's easy to find out about, that it's easy to qualify for, that to raise the income eligibility level so that more people are eligible for these programs. So that's what we'll be pushing this coming year. And it kind of is sort of the way you mop up after what Alex laid out in terms of, you know, how patients get in that circumstance in the first place.
And Mark, what did the governor just sign?
Yeah, there was a bill that we got through this past year. Again, it's sort of step by step by step, but this year's bill was one that forbids now hospital systems that go to court for judgments to get what they're owed back. To prevent, they can no longer place liens on homes, primary residences, and they can no longer garnish people's wages.
Okay.
So that's, you know, those are some new good protections that are in place to help people out.
But it doesn't really deal with how you get people out of debt in the first place, or
Debt, yes,
or
yes.
why they
That's
get
what
in.
this next bill will help to do, along with ideas that Alex's coalition is putting forward, is like, how do we moderate and bring down hospital prices and control them?
I just have to add, I'm sorry, Mark, just one point that gets lost here. Every private hospital in New York is a nonprofit charitable organization. The idea that nonprofit charities are putting liens on people's homes to demand money those people don't have is I mean, we just need, I need to continue to say that these are nonprofits with billions of dollars of tax breaks who are doing this behavior. Mark's exactly right, and it's so egregious.
Yeah, exactly.
Right. I just think maybe we need to separate child and adult, you know, child, you know, up to 18 years old versus when we talk about health insurance or like a family type of thing, because when we look at job security now, if you're paying $300 per month for insurance, that can really impede on your pocket, you know, with all the costs that you may have, rent, food, luxuries, you know, traveling to and from work. you know, so it's kind of like getting like an all-inclusive model or separating the child, family versus adult kind of thing. I think that's where the bottom line is going to be, because, you know, we have a pediatric population that has different needs than adults,
Yeah, we
you
have
know, so.
us child health insurance program here in New York that provides free care for kids in families up to 400% of the federal poverty level, and above that, really low cost coverage. So people who are struggling with coverage for their kids, we have a terrific CHIP program. Get your kids enrolled in it. There's no reason not to. No reason.
Okay. So another question, or would one of our panelists like to pose a question to the other panelists? So.
Well, let me
Okay.
pose a question.
Okay, go ahead.
Peter, and maybe your members, like, you're all leaders of religious congregations, either pastors or lay leaders, I presume.
Yeah.
And so how do you see some of these issues bubbling up in your line of work in your communities? Because real life stories from people like you and physicians and whatever are sort of the grist of the mill that we use when we do our advocacy work. So I'd be curious to hear some of what you're coming across in your own day-to-day experiences. Like, are we on track? Are we off base? Are we missing something? Like,
No, I don't think you're missing anything, but I guess if I could, maybe offer, when I was serving as a pastor, some fairly typical stories. A big one is what happens with long-term care. You have a relatively stable family who's now retired, a couple, but one has a health crisis that necessitates them having to go into long-term care. $10,000 a month with no long-term health care insurance could just blow that family out of the water. Their life savings could go away. You know, all that they work to earn and save is just spent like topsy. And so, you know, the question really is, when you try to offer pastoral care there, you can go and pray for the person and try to offer whatever comfort you can as a pastor, but you got to be asking yourself what else you're doing that could take on the system that just financially devastates people.
Well, with palliative care, I think that we need to look at life differently, like as it was first seen, you know, find mechanisms, use technology, and not give people false hope, but you have to give encouragement. You know, I know we have a lifespan, but if we think about it from a theological perspective, we're really not supposed to perish. So, you know, it's finding the appropriate tools to promote longevity.
Yeah, and it's difficult. We don't, you know, Medicare doesn't finance long-term care. Medicaid does so, but only after a spend down. So that means whatever it is that you've saved throughout your life, you have to run out of. There was, for a brief period of time, long-term care insurance, but that market kind of blew up. It spiraled into the ground because the cost of long-term care rose so much faster than the amount of premiums people had been paying in the 80s and 90s and however long. So it's something that structurally we do not have an answer for in the United States, that that we kind of need to to come together and solve.
I mean, my mantra has always been as an activist, if you think healthcare policy is difficult, you just wait till you get to long-term care. Because it is like all the problems in healthcare that some of which we talked about, kind of like on steroids. And we don't have a solution or anything in place. It's clear the private market won't work. And so we have a default system that's not by design at all. It's called Medicaid. You have to impoverish yourself and live in poverty in order to get services that you need, which is just at the point of the end of your life, or when you have a serious illness or permanent disability. That's what we make people do as a
Yeah.
society.
One of my first introductions to the New York Health Act was going to an event that put on by the Campaign for New York Health, which is the coalition behind it, at the 92nd Street Y. So it's on the Upper East Side of Manhattan. And it was packed. And there were people who were angry at the leadership up on stage, not because of, what we think maybe that this population of people would think about quote unquote socialized medicine. No, they were mad because they were like, y'all have been in here promising us all this free healthcare, and where is it? My mom needs long-term care, whatever, like so many people. I mean, it cuts, like long-term care is an issue that cuts across every single sector of society. There is no way to finance it unless you spend all of your money and you have nothing to hand down, which you might have been like working your whole life scrimping and saving to amass. It's just, it just doesn't have an answer.
Yeah.
Well, like my telehealth practice is called state healthcare. So we're looking to change the way we view public and environmental health. So having a patient monitoring system is great. That's one way we can kind of rectify the situation. You have inpatient and outpatient models where, like Peter explained, long-term care. So that's an inpatient model. And then you have outpatient models where people choose to go home to live the duration of their life, out. So it's just, having a great patient monitoring system. And again, using technology and using the resources necessary to promote wellness and not wasting of the human body.
Yeah.
I guess, and this is similar to this dynamic that Alex was describing with acute healthcare services where we go to hospitals. So for long-term care, there has been a strong push that's been tried to some success to move long-term care services as much as possible out of institutional settings like nursing homes and into the community, which is where people want to live, first of all. And it's a whole lot cheaper, and the care can be provided just as well, if not better. Now, that's not to say we don't need nursing homes, because there is a role for nursing homes, but it's just to say that if we're going to shift our resources in this other way, like what Alex was describing, we are up against the nursing home industry, which is probably right up there with Greater New York Hospital Association in terms of their political power in Albany. And so they always make sure that they get what they want and need to keep their operations going. And what's left on the table afterwards is a bunch of crumbs that the rest of us have to fight. And
There's a great, sorry.
I'm sorry, go ahead.
Well, there's a great new report from the New York legal advocacy group, NILAG, about the interactions between managed long-term care plans, which is the private insurers' long-term care arm, and the incentives that are set up by the state reimbursement systems. Basically, they, if the person is on their long-term care plan, gets put into a nursing home, they get disenrolled from the plan. So the highest profit plans push the enrollees who need care into those nursing homes just to get them off their books so that they can make the most money. Even though some of those people would be best served by just having intensive care services, but at home, it would be cheaper in total and perhaps better for that patient, but might not be best for the insurer in that operation. So it's a great analysis just from the last few months. And my guess is that there's going to be some good advocacy and policies, solutions surrounding that particular issue maybe in the next year or so.
The other thing to note when it comes to long-term care is the Supreme Court ruled over 20 years ago that people needing long-term care have a right to live in the community. And they cannot be shoved into institutional settings against their will. Yet we have structured the system and all the financial, just as Naomi was describing, so that people end up in institutions where, particularly in the midst of a pandemic 3 years ago, the highest death rates were far and away in nursing homes. And so it's not to put down nursing homes, they have a role, but we need some balance here.
Yeah, and I was just going to say, Mark, that part of the other thing that comes up for a lot of parishioners, many times in churches you have an elderly church population, is home care.
Yeah.
I don't want to go to a nursing home, but I can't find people who will work that I can afford, or even if I could afford it, I can't find people who are willing to do it. And that came down to the whole campaign around what we pay home care workers, which we saw a little progress in the last legislative session, but it was still far short of what's needed. And also trying to break up 24-hour shifts and have people paid for every hour that they work is another thing. But if we want to pull pressure down on nursing homes, we got to be looking at much more robust funding for home health care.
Yeah. Alice Union 32BJ, their sister healthcare union, 1199, the biggest union in New York State, or maybe NYSEG is bigger, I don't know. But at any rate, they're very much pushing this whole Fair Pay for Home Care campaign to provide services in the homes and communities for people. And the workforce, as Peter mentioned, it's just not there in certain parts of the state. It's just not there. You can be qualified for Medicaid, everything's lined up, ready for you to go, and there's nobody to come to your house.
Yeah.
And so that's what this is about, is how do you attract people into that workforce? How do you retain them in that workforce and provide a career ladder for their own professional development and all of that? Yeah.
Right. Okay. Thank you, everyone. We're at 9:04, so we're going to conclude our time here.
Oh,
I
no.
just want to thank everyone for sharing their perspectives here today. This is being recorded. We are going to take this information and try to build it into a legislative ask for the 2023 legislative session. Mark, we may be calling on you and also Alex to elucidate that a little bit more so that that presentation is sharp. And we're just so grateful for all of what was shared here today. So thank you so much.
Thanks, everybody.
Thank you, thank you, thank you.
Thanks, everyone.
Right.
Good night.
Thank you so much. Good night, everyone. It was great meeting with you.
Yes.
I appreciate it.